Greetings. I'm Jim Shea with the Acoustic Neuroma Association, and I'd like to welcome everyone to our 2025 ANAwareness Week. In a moment, we'll hear from the expert team at the Ohio State University Wexner Medical Center and their presentation of Managing Expectations as a Newly Diagnosed Patient. Before we meet everyone, just a few quick notes. Captions are available for this presentation. You can turn those on at the bottom of your screen. Also, a reminder to keep an eye on our social media, this week especially. This is a week filled with tremendous information that spans the AN journey. We're on Facebook, Instagram, and even LinkedIn. You can learn about the resources available and how you can be more involved with the ANA. The ANA is here to help, so please access those opportunities. And now, doctors, if you'd like to introduce yourselves, we can get started.
Hey everyone, my name is Dr. Adunka. I'm one of the physicians at Ohio State, one of the ENTs. Glad to be here, and thanks for having us.
So I'm Rob Masalak, also one of the ENTs at The Ohio State University. Thank you very much for listening to our talk today.
I'm Dr. Yin Ren. I'm also one of the ENTs at Ohio State.
I'm Dr. Kyle Wu. I'm one of the neurosurgeons at Ohio State as well, and thanks for the opportunity to share this discussion with everyone.
And I will say too, we will have some additional team members joining on a little bit later in the session. So kind of loop them into things as they join. So as said, our presentation today is Managing Expectations as a Newly Diagnosed Acoustic Neuroma patient. Again, we are the Ohio State University Wexner Medical Center Acoustic Neuroma Vestibular Schwannoma group. You met some of these people, but those who might join or other members of our team include Dr. Desi Shu, Dr. Daniel Prevedello, and Dr. Russell Lonzer. The latter two being neurosurgeons and Dr. Shu being an ENT. So when we were kind of posed this question, I think we all kind of had the goal of conveying as much information as possible, but not overwhelming people with information. So we actually thought that although we will have some questions later in the session, it might be an easy way to approach this topic of a new diagnosis by discussing some basic questions regarding acoustic neuroma care, with the goal of understanding expectations and what your journey might look like at different steps along the way, acknowledging that there are some unique scenarios too that might drive the discussion one way or another. So then moving on to our discussions here. So for, again, just kind of basic questions, what is an acoustic neuroma of vestibular schwannoma? I'll kind of get started here, but an acoustic neuroma is a benign brain tumor on the hearing and balance nerve. It generally presents, as we'll talk about, with hearing loss, sometimes dizziness, as well as other potential symptoms based on what might be being affected by the tumor. But ultimately, it is a tumor near the brain. So with that, it can have some pretty substantial consequences. That being said, a lot of experts in the field are able to kind of work with you to get a good care plan going forward, depending on what's going on with you as a patient, your symptoms, and the tumor itself, to help optimize your outcome and hopefully get you a good result. Okay. So moving on to our next question. Is this life-threatening, an acoustic neuroma? Is this cancer? Can maybe Dr. Adunka kind of chime in on this question and how you typically talk to patients about this?
Yeah, thanks, Rob. Yeah, certainly. So most cases of acoustic tumors are not diagnosed when they're at a life-threatening stage. That being said, they're very large tumors that we sometimes can see on folks that certainly can be a life-threatening situation if the tumor gets to a size where it really impacts the health of the brain, right? So for that being said, those are tumors that are usually over 5 centimeters. in size. Generally speaking, however, most tumors are diagnosed when they're much, much smaller, right? The most important thing is actually that we want to avoid tumor getting to that size. Why that's what diagnosing properly with an MRI early on and, in the journey. So when symptoms are of usually unilateral hearing loss or then dizziness, right, we really recommend not to ignore these symptoms, right? This way, the MRI can be done sooner rather than later, and we can capture these tumors or diagnose these tumors when they're, again, smaller, right? So the vast majority of tumors, they're certainly not life-threatening. Again, it's a benign growth, as Dr. Masalek said, or the hearing and balance nerve. Timely diagnosis is certainly very, very critical. Right. So when your treating physician recommends an MRI, we usually recommend just going forward with that because that's the only way to really reliably diagnose these growths.
Yeah, thank you. Yeah, I just want to emphasize, when a lot of people hear brain tumor, they worry about that this might be life-threatening. But as Dr. Adunka pointed out, in the majority of cases, it's not acutely life-threatening, and we have some time to talk through things, certainly depending on a specific patient's situation. Who might patients need to see for this diagnosis? Dr. Wu, could you maybe provide some insight on, what team members we generally kind of loop into the conversation with a patient after a new diagnosis?
Definitely. Yeah, so typically patients who have this diagnosis, they present oftentimes with, function changes that affect the nerves that Dr. Adunka and Dr. Maslach mentioned. It could be decreases in hearing, it could be changes in balance, it could be tinnitus or ringing in the ear, or it could be vertigo. And, with larger tumors like Dr. Adunka mentioned, they can cause brainstem compression, imbalance, and other changes, even facial weakness. So typically, those are symptoms that a doctor will refer you to an ear, nose, and throat surgeon for, specifically a neurotologist, like all the specialists on this panel. Or you may see myself, Dr. Prevedella, or Dr. Lanza on the neurosurgical side, as both of us treat these pathologies. Now, in certain centers and centers like ours, we see a lot of these diagnoses. And we think it's best for patients to see both of our teams because we work together both in and out of the operating room. It's a very complex pathology, as Dr. Adunka mentioned. There are many various aspects to these tumors that can cause problems, right? There's the nerves themselves, which, like we mentioned, hearing, balance, dizziness, and then also the brainstem, which Dr. Prevedella, myself, and Dr. Lanza really care about. If there's brainstem compression or crushing of the brainstem, that can affect your ability to walk or to move or to interact with your world. Furthermore, some tumors, even if they're not that large, even on the smaller to medium size, can secrete what we think is proteins that can affect the fluid-filled space of the brain, lead to something called hydrocephalus, which may require a shunt. And so really, those shunts and hydrocephalus is something that neurosurgeons primarily manage. Some of those other functions are primarily managed by the neurotology team. So as you can see, by the complexity of this disease and the different functions it can affect, it's really important for a patient to see both of us. So whenever a patient comes into my office, I will immediately refer them as well to one of my colleagues and vice versa, just to make sure the patient understands all the different options for treating these tumors and understands all the baseline functions. And so we work on that together. We may order tests like hearing tests, potentially even swallowing tests, the tumors affecting that function. And the other services that we may work with on tumors includes radiation oncology. Sometimes tumors of certain sizes or certain locations may be amenable to radiation. And so we want to make that judgment in a multidisciplinary fashion. Even as surgeons, we want to make sure that patients understand all of the options they have: observation, radiation, or surgery. And so we make it very clear those possibilities and allow patients to see all of us and encourage it. And we'll make sure that the referral is made to all of us to get the holistic picture.
Perfect. Thank you, Dr. Wu. So next question here. With this diagnosis, am I going to lose my hearing? Dr. Wren, do you mind talking about this, acknowledging that there's a lot of nuance to this question?
Sure. Yeah, I think this is one of the most commonly asked questions. I think it's one that affects almost all the patients with acoustic neuromas, and certainly there's been a lot of data published over the years on this topic. So I'll just briefly highlight kind of what we know and what we don't know. Vestibular schwannomas they grow from the balance nerve. However, the most common symptom is hearing loss. Roughly 95% of patients with vestibular schwannomas will have hearing loss, and maybe about 2/3 or 70% of those will have tinnitus and imbalance. So with hearing loss being the most common, there's a wide range. Some patients lose most of their hearing. Others may lose only a little bit. And some lose their hearing quickly. In some cases, what we call it a sudden hearing loss. They can lose it over a matter of days or weeks. But more commonly, they lose hearing progressively over a period of months to years. In general, when we take everybody as with vestibular schwannomas, all tumor sizes, all hearing together, roughly the number we typically would say is, if you start with normal hearing, you will gradually lose, your what we call a serviceable hearing, meaning hearing that you can still use a hearing aid for roughly 50% of the time by about 5 to 7 years. So, if we just watch everyone with a vestibular schwannoma, in about 5 to 7 years, roughly 50% of patients will end up losing their hearing. Now, obviously, everyone is different, and some may lose quicker and others may not. The other thing that people have found is that the rate of hearing loss or the likelihood of hearing loss, it doesn't necessarily correlate with the tumor size or the growth rate. In some cases, a faster growing tumor typically is thought to be more likely to cause hearing loss, but not always. And certainly we all have seen patients who have very small tumors, but are essentially have no hearing in that ear, and patients who often have very big tumors and have nearly normal hearing, and they were presenting with some other symptoms. So there's still a lot of unknowns that regarding to hearing that we don't quite know, exactly what the future hold. And then in terms of the treatment, I think we're going to talk about probably the treatments later on. But each treatment, whether it's radiation, whether it's the type of surgeries we do, all have different impacts on hearing. Some are designed to sacrifice hearing, such as the translabyrinthine surgery, where we essentially go through the inner ear to remove the tumor. Others are meant to preserve your hearing, such as the retrosigmoid or the middle fossa approaches. So again, that decision is made jointly by the whole treatment team.
Perfect. Thank you, Dr. Wren. So the next question, I can kind of take the lead on this. With this diagnosis, am I going to be dizzy? Now, Dr. Wren touched on a couple things that I think are relevant here. In part, he mentioned that this tumor grows on the balance nerve primarily. So automatically hearing that, you might think, oh, I'm going to be dizzy when I have this. However, unlike hearing, we don't often see as overt signs of dizziness in these patients, in patients with acoustic neuroma. Oftentimes they might present with some vague imbalance or at times vertigo, like a sensation of room spinning. However, it's much less common, I would say, to present with overt dizziness as compared to hearing loss. Dr. Wren also touched on a couple different things that as we, go throughout the course of this disease, there's potential for worsening balance function. That's in part due to worsening balance function relating to the balance system itself. but also, as Dr. Adunka had mentioned earlier, could be seen in tumors that are a little bit bigger and pushing on the brainstem and cerebellum that might lead to clumsiness or imbalance and things like that. So dizziness in of itself is probably not as clean as hearing loss, and that might be why we don't always associate it with this diagnosis, but certainly it's a component and a symptom that a lot of patients experience at some point after their diagnosis and during their management course. We'll talk about a little bit more in depth different management options and how that can result in different levels of dizziness specifically. All right. So next question here. Maybe for Dr. Adunka, is this a genetic condition? Do I need to be tested or have my children tested?
Yeah, great question. And something certainly a common question, I think, with especially folks who have this diagnosed, first. So the vast majority of acoustic tumors are what we call sporadic acoustic tumors, so they're non-hereditary. So usually this is not a genetic condition, right? A subtype of acoustic tumors are due to what we call neurofibromatosis type 2. Really NF2 related schwannomatosis, right? So neurofibromatosis type 2 related schwannomatosis. In some other countries, to call it Van Recklinghausen's disease, there are other names for it, right? But really, it's the newer terminology is NF2 related schwannomatosis, right? And folks who have that have a genetic condition, right? 50 to 60% of these cases are due to new mutations, whereas about 40 to 50% can be inherited. Where usually the inheritance pattern is that every generation is typically affected by this. Again, it's just a subtype. Again, the vast majority of folks that are diagnosed with a acoustic tumor will not have that and will be again what we call a sporadic acoustic tumor, but certainly that's something that we look for. If folks are diagnosed and they're really young, right, and have really big tumors, usually that's when we look for this and do some genetic testing. It's some relatively simple genetic testing that can be done by nowadays even some commercially available genetic testing kits, almost like 23andMe. Certainly, if that's the case, we would involve a geneticist, right, to help us with that. Usually every big medical center would have a department that can help. But again, most of the time it's not necessary, and these are sporadic cases that are not due to a genetic condition.
Perfect. Thank you, Dr. Adunka. So next question here, maybe for Dr. Wu. What can be done for this? Do I need surgery?
Thanks, Dr. Maslach. Yes, I think, as I kind of alluded to earlier, there are a couple of options here. And I am lucky enough that I have equipoise here. I am a radiosurgeon as well as a neurosurgeon. So I provide radiotherapy for certain specific types of tumors. So, there are certain criteria we think about, and it's really it's a little bit of an art for these tumors. When we think about how to approach this, there's three major options, right? We mentioned observation, radiation, and surgery. And as we mentioned, we have the patient see all of our different teams to discuss these various options. When we think about it, we take into account all the things that were just discussed. What deficits are existing? Do we have problems with hearing? Is there hearing loss? Is the tumor growing? Is it growing quickly? Do we have a genetic component to the tumor? Is radiation going to affect that and increase risk of transformation of the tumor into a more aggressive tumor? Is there brainstem compression? Is there hydrocephalus? So it's a really, really complex question that I'd feel a little uncomfortable answering point blank on this. And I think really patients should seek the expertise of a high volume center that does a lot of these surgeries and has all of the services that a center like ours or some of the others that were shown at the beginning offer. The bottom line is the question, do I need surgery? Hopefully for the patient, the answer is no. Even as surgeons, and although we're very good at surgery and taking care of these tumors and have really good outcomes, we always hope for our patients that we can avoid an invasive procedure if possible. This is why the discussion and really trust and working with your doctors is so important, because when patients come to us, we want to make sure that we're doing the right thing for them. It may be just watching the tumor, it may be radiation, and it may actually be a surgery. Just because surgery may be the more invasive option does not always mean that it is the worst thing for the patient. Large tumors that need to have pressure taken off the brainstem, for example, that is a need surgery case. But even some smaller tumors that are in the middle, if patients really value their hearing, and we have the opportunity to preserve a patient's hearing rather than letting it decline over time with observation or radiation, that is also a scenario where surgery would be helpful. So I think we really want to take into account the patient's goals, their deficits, and the whole situation. Dr. Duncan, do you have something else to add there?
No, I think you answered it very well. I think, it's just statistically speaking, right, when we see these, and most patients come through an ENT, right, just because of the symptom of hearing loss or dizziness, triggers their MRI. So I think, from the patients that I see, about only a third of them really will immediately get surgery. And that's usually what Dr. Wu said, either really big tumors or really small tumors where we can actually preserve hearing, right? So, but the vast majority of tumors, we usually just watch, get MRIs and just to assess their biological behavior, right? Are they growing tumors? What have they done to hearing, right? So there's only a few variables, right? But usually it gets pretty complex, in terms of all the kind of decisions that are there, and considering all the factors and quality of life, really, right? So, but I completely agree. Yeah, thanks for answering that.
All right, so I could maybe just weigh in on this to kind of tag off of that. Are all management options available to all patients? So I think both Dr. Wu and Dr. Dunca highlighted the fact that in a lot of cases, yes, all management options are available to patients. We talked about surveillance, radiation, and surgery. However, there are some situations where we do recommend things maybe more specifically. A good example is a younger patient with a larger tumor. We're generally going to recommend doing something because when we're addressing this tumor for a patient, we're thinking about the quality of life across their lifetime, not just immediately. So when we see that larger tumor in a younger patient, we might say, well, it makes sense because at some point we're going to have to do this. So to answer this question, yes, in the majority of cases they are available, but there are certain situations where we might have stronger opinions than others on where that management might occur or which way that management might go. Maybe for Dr. Ren, this also tags along with that. If I need treatment, do I need it emergently? Or is this something that, if they schedule my surgery out a couple weeks, it's okay?
Yeah, I think for the most part, it's not something that needs to be um, done emergently. Although there are sometimes cases where, in rare cases where there's a very large tumor, or if there's signs of brainstem compression or significant hydrocephalus, that the pressure off the brain needs to be taken off, then those procedures, not the tumor resection per se, but some of those procedures had to be done in a rather expedited fashion. But that's rare. For the most part, if you were diagnosed with this tumor, in an ENT or neurosurgeon's outpatient setting in their office, usually there's time to consider the various treatment options, to think about what would be the pros and cons of each, what would be important in terms of the quality of life, the type of operation or radiation that someone is going through, and making a plan usually within a few weeks or even a few months of this diagnosis is fairly common. So I would say the vast majority of cases, it's not emergency. Certainly not something you want to forget about. But there are rare cases where usually the procedure is done more emergently for things like hydrocephalus or brainstem compression.
Perfect. Thank you, Dr. Wren. So we've touched on this a little bit, but maybe I can take the lead on this one, and then we'll be able to go through and talk about the different surgeries on the next slides. But if I have a surgery, will I lose my hearing? Will my face be weak? I think this is a pretty nuanced question and is hard for probably all of us to give a generalized statement about. As we'll talk about, each of the different approaches carry different risks to your hearing. But in of itself, just having this tumor puts your hearing at risk. And there's certain tumor characteristics, mainly tumor size, that put your hearing at higher risk if you do have surgery. Now, when we talk about facial function, we generally prioritize that pretty highly in the management of these patients. So when we talk about that, we really focus on how best to address the face and help make sure that that doesn't become weak with surgery. However, there's a lot of situations where, despite our best efforts, there might be some temporary weakness after surgery. Again, that's largely driven by certain tumor characteristics, but as mentioned earlier by Dr. Wu, being at a high volume center can generally help this too, because that basically shows that those physicians have experience in managing these tumors surgically and optimizing outcomes like facial function. So no, in every situation, your face isn't going to necessarily be weak, but it's something that we consider every time we do surgery, and we work tirelessly to assure that that's not going to happen. So maybe Dr. Ardunka, what can I expect if I have a translabyrinthine approach for surgery? And maybe you could talk about within this, our practice here at Ohio State, like what that looks like for patients if you were to come here for surgery.
Sure. Thank you, Rob. Yeah, so a translabyrinthine approach is pretty much an approach what mentioned previously where we go through the inner ear, right? It does not allow us to preserve hearing, right? So it's for someone who typically does not have serviceable hearing prior to surgery. It's also a very safe approach, right? It's usually the ones that is an ear surgery, right? Where we just go through the brain after that. It really allows us to remove tumors of all sizes, right? We're not really limited to any specific size. So in fact, for really large tumors, it's a very kind of patient-friendly approach for the overall recovery. Surgery is done from behind the ear, right? We would go through the bone behind here. It's called the mastoid bone. That's the bone that's connected to the middle ear. And again, we're unable to preserve hearing with this approach. And the trade-off here is that it's usually the one that's best tolerated by the patient, right? As evidenced by, several groups have demonstrated the hospitalization stay is usually a little shorter. So generally speaking, well-tolerated approach. Again, no hearing preservation possible. What we've recently done with this approach is we basically are able to provide a cochlear implant for those smaller tumors where we can preserve that hearing nerve, right? We, at the same time, because all necessary steps for the cochlear implants are performed during the surgery, that we can, in some cases, provide the cochlear implant right then. So that's more recent development that this approach allows and is really good at.
Perfect. Thank you, Dr. Ardunka. So next question here, same question, but for the retrosigmoid approach. Dr. Wu, could you maybe weigh in on this?
Of course, yeah. The retrosigmoid approach is considered a workhorse approach for neurosurgeons. It's a kind of must-learn, must-know way to access the brain for a variety of different pathologies, not just vestibular schwannomas. The retrosigmoid approach, we've been doing it for decades, around a century almost. And what we do is we take off the bone behind the sigmoid sinus, which is hence the name retro sigmoid. And what we do is we take off the bone behind that space, open the lining of the brain, and that allows us to access a large area all the way up to the tentorium, which is the top of the posterior fossa, all the way down to the foramen magnum, which is the bottom of the posterior fossa. So the whole region kind of behind the ear, from this region down to this region, beginning of the neck. The view it affords us is phenomenal. It allows us to see all the nerves. They can be oftentimes the way the vestibular schwannomas in sporadic cases especially grow. We encounter the nerves kind of on the back or the far side of the tumor. It also gives us a good view of the brainstem if we need to achieve brainstem decompression to remove pressure off of the brainstem. In addition, it allows us to save hearing and the cochlear nerve. And so we work tirelessly, as Dr. Maslach said, to try to dissect the cochlear nerve off from the tumor. And so this can give us a chance of a hearing preservation with this approach, which is in the certain patients and the right patients can be something that we really favor. Besides that, it also gives access to the facial nerve, as Dr. Odunko was mentioning, and the translabyrinthine approach. And so it gives us a chance to save that nerve. And as we mentioned earlier, in high volume centers like ours, we have very good success with saving that function. So the choice between the two, there's no right or wrong answer. There's no better or worse. It's really patient specific. If we're going for a hearing preservation approach, we will favor the retrosigmoid approach. But if the anatomy dictates otherwise, they are both reasonable approaches to try to remove the tumor and get it out of the patient.
Perfect. Thank you, Dr. Wu. And then for Dr. Ren, maybe could you add what situations we talk about a midocranial fossa approach and what a patient could expect if they do undergo that approach?
Sure. So middle fossa approach is probably the most selective in terms of the type of patients that would be candidates for. Typically, it's reserved for tumors that are on the smaller side. Usually, we talk about tumors that are located mostly inside the bony tunnel, the internal auditory canal. So which means usually it's tumors less than 15 millimeters. Patients usually have pretty good hearing. So if you don't have any hearing left because of the tumor, then this approach doesn't quite make sense because it's designed to try to preserve whatever hearing you have left. And rather than the translabyrinthine and the retrosigmoid approach, where you're coming from behind the ear, this one you're approaching it from above the ear, kind of from the middle cranial fossa, which is really the part of the brain that sits above the ear. So it's a different approach. Usually we select it for patients, again, with smaller tumors, with relatively good hearing, and also usually a younger age patient population as well. So yeah, I'll leave it at that.
Perfect. Thank you, Dr. Ren. And I would also like to emphasize too, across those three different approaches here at Ohio State, most patients do spend certainly a few days in the hospital, but generally I would say about 2 to 3 days in the patients we manage. So it's not a prolonged hospital course or anything like that in the majority of cases if we do go forward with surgery. All right. As we move on from surgery to radiation, kind of similar questions relating to that. So if I have radiation, will I lose my hearing? Will my face be weak? So I can kind of take this one. So will I lose my hearing? Now, the data shows that in the majority of patients, over a long enough time after having had radiation to manage their tumor and stop it from growing further, they will unfortunately lose the remaining hearing that they have. Now, that's not 100% of the time, but it is in the majority of patients. So it's certainly something we consider. And generally don't talk about this with patients unless their hearing has kind of progressed to the point that it really is non-functional. Now, will my face be weak? Unlike surgery, there's not that acute risk to facial nerve function. However, there is a very small risk in some patients to have some potential temporary or permanent weakness after radiation. Now, that is a lower number than typical that might be typically associated with surgery. However, when you talk about the patients that are eligible for this type of treatment and then the potential risk for future growth, some data supports that the long-term risk to facial nerve function might be similar between having radiation first versus having surgery first. Certainly, as with this question when we talked about surgery, there's a lot of nuance here, so it is difficult to make some kind of generalized statements. So maybe for Dr. Wu, who, as noted, is a practitioner of radiosurgery, can you talk about what you can expect if you have radiosurgery? Again, maybe in the context of receiving care here at OSU.
Yeah, for sure. Radiosurgery for vestibular schwannomas is typically performed in the Gamma Knife suite that we have here. It's done in a single treatment, and it's done with Gamma Knife because it's highly accurate and can avoid dosing areas such as the cochlea and the semicircular canals. You want to avoid causing ototoxicity or damage to hearing from the radiation treatment. In addition, because these tumors often can be close to the brainstem and other important areas, this allows us to have a really highly conformal approach to treating the tumor. The sessions for Gamma Knife, as I mentioned, we have patients fixed typically with a frame or a mask, depending on the tumor itself and its morphology. But basically, the patient will be fixed with sedation and immobilized to receive the treatment. Treatments usually last anywhere between an hour to a couple of hours, and then the patient can actually go home the same day. I think just to tag on to the hearing question that Dr. Maslach had mentioned, with radiosurgery, it does have a similar kind of degradation in hearing as the natural history of hearing loss from the tumor. So, when we consider this option, I just want to make sure that we kind of double emphasize the fact that radiosurgery is not intended to save hearing. It doesn't risk your hearing during the actual procedure, but the expectation for the patient and for ourselves as practitioners that over time, that patient will continue to lose hearing. So if a hearing preservation approach is attempted or desired for a patient, for example, if we have a young musician that we operated on recently, we may recommend surgery in that case. So, it is a very useful tool. The risk profile during the procedure is low, but that risk is kind of amortized over time. And so when we make our decisions, we want to keep all of these things in our minds.
Thank you, Dr. Wu. Yeah, just again emphasizing, I think I mentioned it earlier, that when we talk about acoustic neuroma care, we talk about it over a lifetime, not necessarily just an acute treatment time. So an important consideration there. So next question here. Maybe for Dr. Adunka, do you ever need more than one form of treatment, or is it surgery and done or radiation and done?
Yeah, it's a great question. So, and it varies a little bit across the country, right? So we certainly are big believers in if you get an acoustic tumor treated, specifically surgery, right? And our goal is really gross total resection, right? Meaning gross total resection is kind of our medical terminology for taking all the tumor out, right? And because we believe in, if a patient undergoes surgery, we certainly feel like they want to be done with it, right? To do this, a lot of tumors we don't do surgery on, and then of course you know that you still have this growth in there. But if you do surgery, then we really like to take care of the patient, and remove the tumor entirely. Unfortunately, it's not always possible, specifically really large tumors, with they're really stuck to the facial nerve. We recognize that sometimes either a subtotal resection where we leave a remnant of tumor behind that usually covers the facial nerve. That's usually that veil of tumor that's left across, to protect that facial nerve that's necessary, because we really don't want to harm the facial nerve, right? So I think the number one goal that we usually communicate with patients is really to not harm the facial nerve, right? while also taking all the tumor out. And if sometimes we can remove 99.9% of the tumor, really, and we have to leave just a sliver of tumor on the facial nerve. That's what we call it near total resection, right? And really, that's in the literature, that's really defined as leaving a slight tumor remnant, and that's really been cut off from the blood supply. And most of the time, we can't even see those on MRIs after surgery, right? So again, gross total resection, complete removal of tumor, right? Subtotal resection, a measurable, amount of tumor is left, usually on the facial nerve, and the near total resection where tumor is left that usually we can't detect via MRI, and usually they're not a problem afterwards. Now, with subtotal resections, we usually would monitor that residual tumor over time, right? So what happens if we leave tumor behind? That tumor, which is usually a veil, will roll up into a ball, will ball up into kind of a more round structure after 3 to 6 months after surgery, and then we would follow that with MRIs just to make sure this doesn't grow. If there is growth or residual, we usually would consider surgery after that. So usually that's kind of process. But again, our goal is to just have one treatment, meaning that we can provide that gross total resection rather than to have to engage in both surgery as well as radiation afterwards. And I would say in our experience, that's not common.
Perfect. Thank you, Dr. Adunka. Okay, so getting near the end here. If I observe my tumor, what can happen to my tumor and what can happen to my hearing? Dr. Wren, could you maybe take this one?
Yeah, I think I talked a little bit about this earlier. So in terms of what happened to my tumor, I think again we talk about data that we've looked at as a field, but again for each person, it's different. But in general, most of the tumors that we end up observing, most of the growth happens within the first 5 years, and I would say maybe about 20%. Or 20 to 30% of most of those tumors that we observe actually demonstrate growth. So the vast majority of tumors that we observe don't grow. But now there's a slight selection bias there, because if a tumor that we see are on the bigger side in a relatively younger patient, it took some time to get to that size. So we think that the chance of it growing, if we end up choosing to observe, is high. So some of those tumors we end up operating on, without observing them for a long time. But as a whole, I would say, for most tumors, we observe for at least for 1 or 2 MRI scans, maybe over the 6 to 12 months, to see if there's any growth. And a significant portion of them, as I said before, 70 to 80% of tumors don't grow. And of those tumors that do grow, most of those grow within the first 5 years. And usually the smaller the tumor is, the less likely that the tumor will grow. So most of the data that we sort of based our decisions on is from these national databases coming out of Denmark and the UK. And they looked at tumors that were observed over 10 to 15 years. And usually the tumors that are small, that are inside the internal auditory canal, the chance of them growing is much lower than those tumors that are larger. In terms of hearing, I think that it gets a little more complicated, because a lot more factors can affect hearing loss even when tumors don't grow. So you could still have hearing loss progressively even in the setting of a non-growing tumor due to reasons I talked about, since we don't know exactly why someone can lose their hearing, whether it's tumor causing some kind of inner ear damage, compressing on the nerve, disrupting the blood supply to the inner ear. But in general, if we observe the tumor, and if you start with essentially normal or close to normal hearing, over the 5 to 7 years, about 50% of those patients will end up losing their hearing to the point where they would not have limited benefit from a hearing aid. Certain treatments can save that hearing if we do surgery and preserve that. Radiosurgery usually does not slow down the rate of hearing decline. In some cases can accelerate it. But in general, hearing declines slowly over time.
Perfect. Thank you, Dr. Wren. So I can handle this one. If I observe my tumor, when will I know if I need treatment? I think we've touched on this a couple of times, but a lot of it is a shared decision between you and your provider. Certainly, if we see growth during observation of a tumor, so that's after getting 1 or 2 MRI scans and we see that it continues to grow, that's when we might discuss treatment. However, it again is really a shared decision between patient and provider, considering all the factors that might be at play. Again, with the goal too of working to optimize quality of life, acknowledging that this is a benign tumor. So I think this might be one of, if not our last question. If I lose my hearing, is it gone forever? Dr. Dunke, you briefly talked about this, so could you maybe pick up, you know, where we've been going in this regard, maybe within the past 5 to 10 years?
Sure, happy to. Yeah, as I mentioned earlier, there's this research, there's kind of national trend, really, not just us, but several other larger centers have really been able to provide cochlear implants, much more consistency, right? And cochlear implants are really devices, hearing devices that are traditionally for folks who have hearing loss on both sides, right? Almost profound hearing loss on both sides. Now, the FDA has, recognized the benefit of cochlear implants for folks who have what we call single-sided deafness, and acoustic tumor patients certainly being a very common scenario that would be, consistent with single-sided deafness. So, either with or without surgery, right? Acoustic tumor surgery, we can provide cochlear implants. Again, also in combination with radio surgery sometimes. So, but there are kind of several scenarios that we can think of, right? One was, I mentioned earlier, the translabyrinthine surgery would remove the tumor but preserve the hearing nerve, and in that setting, we can provide a cochlear implant. Most easily during the time of when we resect the tumor, we remove the tumor. Another option would be, as long as we can preserve that nerve, right? We can do it after a tumor removal from either approach, really, right? Again, as long as that cochlear nerve is preserved, that's really the precondition for that. Other options, again, would be providing that cochlear implant almost irrespective of what we do with the tumor, right? So if we just observe the tumor, but the patient has lost hearing, we can provide a cochlear implant. Or likely that, the patient received radiation, and we can usually provide a well-functioning cochlear implant in those scenarios. So I think if you lost hearing from an acoustic tumor, right, it's not too late necessarily to seek treatment. It depends on the specifics, really, on how big the tumor is, if the cochlear nerve is preserved. But it certainly will make sense to talk to an ENT physician about that, right, and gain their kind of input on whether or not this is possible.
Yeah, perfect. Thank you, Dr. Dunke. And I do believe this is the last question. How do I know if I'm going to the right place to manage my acoustic neuroma or vestibular schwannoma? Dr. Wu, I think you've touched on this a couple of times, so could you maybe talk about what your thoughts in this regard?
Definitely. I know, my colleague, Dr. Papadello, and Dr. Shu are also both able to join us, so they may be able to provide insight as well. But it looks like, when we think about managing your acoustic neuroma, vestibular schwannoma, we want to take into account all of those kind of various aspects of management. We talked about presentation, symptoms, symptom maintenance of function, and quality of life. And like Dr. Maslach said, we think about these things over the course of a patient's life, not in one episode. And so you really want to approach a center that has a lot of experience with patients being managed in multiple different ways. That could be observation, radiation, and surgery. Because if you need to go down any of those pathways that are procedural, especially radiation or surgery, you want really highly trained and experienced physicians. There's a direct correlation with the number of surgeries that you do and your outcomes. And you want to go to a center that is able to manage not just a very smooth surgery, but also complications that can occur after surgery. Some of these surgeries can be very complex, as we mentioned. And so, like we were talking about facial nerve weakness or hearing changes or hearing loss, like Dr. Duncan mentioned, you want to go to a center that has the ability to understand what the options are what can be done for hearing. Or if you have a facial nerve change, maybe slight weakness or even a severe injury, you want to be able to go to a place that that can be managed and has a facial nerve specialist able to help reanimate the face if necessary. So I think, ultimately, if I was a patient, I'd want to go to a place that has a couple of criteria. One, being high volume in terms of managing these tumors, and has a lot of experience managing them in all different modalities, not just one single way. Dr. Prabodella, Dr. Shu, do you have any additional advice for patients, Dr. Adonka, on patients and they approach how to select which practitioners and which centers to work with?
No, I think you mentioned well, Dr. Wu. I would say that one advice for patients is not to be shy of asking that, right? Because sometimes what you describe is like how probably the person out there is thinking, how am I going to know? And if they offer everything. So I think it's good to ask, and it's interesting. You can tell some patients feel more comfortable asking this type of questions, others don't. But you should hear from us that you should be asking and don't be shy. Just ask, how many of these the center, not only one surgeon, that you guys do per year? Do you offer all three type of approaches? Do you offer all three modalities of approach, right? Like involving radiation. Radiations also has multiple types. Like I know Dr. Wu mentioned a gamma knife, but sometimes for some patients, there's a need for larger tumors to do IMRT. There are other modalities of radiation, even SRS with LINAC. In places like Ohio State, we offer those things. And if you feel that there's like a limitation of different alternatives and options there, the certain place is offering, is probably not a bad idea to check on places that have more to offer. I think the end of the day is your head, your brain, that is under, being operated or treated, and it's very important, I think, to be in a center of excellence that can offer all different modalities.
Yeah, maybe one thing, and I agree with everything that's been said. I think the most important thing is, a lot of patients come in and they've read up, they've watched some of these videos here, like this one today. And, I think don't let yourself get pressured into one, treatment modality or not. Frankly, most tumors can be just watched at first, right? I think there's usually nothing wrong with that, right? Unless it's a really, really big tumor with brainstem compression, right? I mean, then the writing's on the wall. But and I think, I can't overemphasize, go to a center that offers radiation and surgery, right? And observation, right? I mean, we look at our data, right? We kind of observe a third of the tumors for a while, or even more than that, right? Over a third, but we offer all approaches. You want to see kind of that patient-centered approach, right? Because if you feel like there's only one approach offered, if only surgery is offered or only radiation, then that's likely what you're going to get, right? So, but you're not at the center as a patient, right? So we really feel like that's patient-centered approach, and don't let anyone, unless again there's some rare, really large tumors that require management more rapidly, right? Don't let yourself get pressured into one kind of modality or the other, right? I think most tumors are not giant, right, and can be watched, and you want to take your time with your decision, right? And it's also not wrong to get a second opinion. People ask us that all the time, and then we can send them to competent folks that we know. Even a virtual consult is possible with most centers, so we feel like that's always a nice approach to get. Make yourself comfortable with it, whatever decision you're going to make.
Yeah. And sorry, hey, this Dr. Shu, I'm just joining a little late, but just to kind of add to those same sentiments and to maybe close out the conversation too is, oftentimes I think about the point of diagnosis or the point of treatment as just being the starting point for the rest of your journey as acoustic neuroma or vestibular schwannoma patients. And so I think another big component of treatment and management of these is, again, how do we manage all of the other symptoms that may come along with it, and being able or being comfortable in knowing that the center that you choose to receive your care at is thinking, about your care more longitudinally, thinking about both your hearing needs, but also your balance needs, and having the skilled providers available, physical therapists and other members of our team that can really help you and other patients along their way, no matter what they need. And so, our goal is never to think of any one patient just as as a treatment option, but really, how do we get them through the rest of their life with this new diagnosis? And so I think that is just as important as all the other things we've talked about tonight. And I think that that's really a key highlight of our team here.
Excellent capstone on that, Dr. Shu. Thank you for that. So I'd like to thank everybody for the participation. Just wanted to highlight our webpage on acoustic neuroma or vestibular schwannoma. Feel free to go to this website if you want to get some more information about our practice, meet our providers again, or schedule any appointments or second opinions if you have those or desire those.
Yeah, I don't know if the ANA had some. Well, I mean, we can stick
Yep.
around and maybe answer some questions you may have.
Absolutely. Doctors, thank you so much. I'll share that before this webinar, we asked our patients, hey, this is the topic. What questions do you want? And you covered so many of them. I think that's a sign of a great presentation. So you anticipated well and gave some great information. So I'm going to just run down a couple of questions. We don't have many left.
All right.
Just even in the last 5 minutes, I was like, wow, they're covering it. Can you go over? Can you address? You talked about large tumors, small tumors, medium tumors. Can you go through the sizes there just for the patients to,
Yeah, great question. Usually when we have the conversation with a newly diagnosed patient, we usually say you have XYZ, you have large, a small, medium, a large, right? Small usually 0 to, or, in the internal canal, that's the bony channel that hosts the nerve, until about 1.5 centimeters. Right, and then 1.5 to 2.5 centimeters, generally considered a medium-sized tumor. I would say it depends a little bit on the head size, right? To say what's the, because you can have a 2.5 centimeter tumor and be really kind of have a smaller frame or smaller head, and that may be biologically a little larger. But generally speaking, 1.5 centimeters to 2.5 centimeters, generally considered a medium-sized tumor. And then 2.5 centimeters and more, really a larger tumor, right? Where usually these tumors do reach the brainstem, right? And they usually have an impact, mechanical impact on the brainstem. And then, of course, really giant tumors, I would say 4.5, 5 centimeters. Again, the head size and the size of the posterior fossa, Dr. Masalak, when he was a medical student, and I published on this actually a number of years ago, and we were able to show that these large tumors are always large tumors and they behave like large tumors, right? They're a little harder for us to deal with. But these medium-sized tumors, depending on the head size, they can behave more of a smaller tumor with a larger person, or a larger tumor with a smaller person, right? So it depends on kind of how much room you have in your head, right?
Okay. Is there a tumor size that's too large for radiation? Do you get to that point?
The literature varies a little bit, right? In the United States, we usually use the 2.5 centimeters, right, as a kind of tougher one for radiation. Recently, we saw radiation failure, with some tumor were radiated that are bigger than that. We're especially worried at radiating larger tumors that have cystic components, right? Because these cysts can really swell acutely from radiation and cause kind of acute problems in brainstem edema, et cetera. So 2.5 centimeters or less, I think, is a fair number. But maybe great to have Dr. Wu, Dr. Prevedel's input on that as neurosurgeons.
Yeah. No, I definitely agree. And like Dr. Prevedella mentioned earlier, I do want to clarify the question that Dr. Maslach had asked was about stereotactic radiosurgery. And there are options, especially for larger tumors, something we call stereotactic radiotherapy, which is done over multiple sessions, hypofractionated, so lower dosages delivered over multiple sessions to achieve an overall higher dose to the tumor. But when we think about radiating tumors, the points that Dr. Duncan mentioned are spot on. Tumors that are compressing the brainstem causing edema, distortion, or compression of the brainstem, we worry about irradiating those tumors as we can get collateral damage to the surrounding tissue. In this case, brainstem is incredibly important, right? But surgery, actually, under the microscope, is the most exact and precise way for us to remove tumors off of the brainstem. So when we see that, we typically will shy away from radiation and lean more towards a microsurgical approach. So when you're talking about size, we're also talking about location, as Dr. Duncan mentioned earlier, whether it's in the canal, in the cistern, and compressing the brainstem. And so, really to answer that question, when we have that scenario with a larger tumor pushing on the brainstem, or a cystic tumor with a large cyst that can swell after being radiated, those are the scenarios where we shy away from radiation and favor microsurgery. Parvidello, do you have anything to add there?
No, not really. I think you guys covered very well. I think the message is like, if it's too big, you need surgery because you need the mechanical decompression and decrease the risk of making things worse with radiation. But one thing that I like to, maybe now that we're at the end, something that I have mentioned to all my patients is that with vestibular schwannomas, we're always juggling with the three modalities, which is observation, surgery, and radiation. And if you grab one of those balls that are juggling, I guess because I juggle, you grab one doesn't mean you're not going to use the other two balls, the spheres, in the future, right? So sometimes you go like, I go for surgery, but sometimes it's such a big tumor, small residual on the facial nerve, you may use radiation in the future for that. That will be a radiation that makes sense versus a radiation to start the process will be too much for a bigger tumor. And so all this is always there as well. So someone that has a smaller tumor goes for radiation doesn't mean that it's completely free of the possibility of that tumor growing in the future, and you may need to use surgery. So there's always observation, radiation, surgery. As the moment that you're diagnosed with a vestibular schwannoma, you have to have that in mind, that you may want to avoid radiation, but it's not completely free of your future that you may need to use for a small recurrence or a small residual in the future too. But I agree with Dr. Duncan that we are always trying, for most of the patients, once we go for surgery, we try to remove everything. We try to avoid any residual, but it is a reality that you're always observing or considering radiation or surgery. And I think that kind of gives us the overview of the triangulation of treatments and part of the care.
Thank you. Last question for everyone. What can patients do pre-treatment when they know they're going to have to make a decision or they've made a decision? What can they do pre-treatment to give themselves the best outcome? What would you suggest they take on?
Maybe Oliver, what came to my mind is something you taught me about, like a vestibular therapy before surgery. That type of thing is something that you may want to touch.
Sorry, Danny, what was that again?
Like the vestibular pre-surgical vestibular therapy as something that be something on the side of the patient that they can do to optimize the outcome. Yeah.
So, and I think we briefly touched on this. We haven't really gone into detail during this webinar. Is the vestibular stuff, right? Which means the balance, right? The vestibule is the balance part of the inner ear, and vestibular symptoms. It's a balance nerve tumor, right? It's not a hearing nerve tumor. It pushes against the hearing nerve. That's why most folks have hearing loss when they're diagnosed, but it really is a balance nerve tumor. And the reality situation is that we can't remove them, right, without cutting at least one of the balance nerves, right? Usually we actually like to cut both of the balance nerves because it's easier for the patient to compensate after surgery, right? And what that process entails is basically that the brain learns to basically not listen to the balance organ of that side, right? So basically it just ignores that symptom and then compensates and just uses the balance information from the other inner ear, right? So that's a process of compensation. And what Dr. Parvidello mentioned is physical therapy can be done after the tumor is removed, and that's usually how it's done. But there's actually quite a bit of data showing that prehab, we call it, so before surgery that we do rehab or vestibular rehabilitation, that actually really cuts down on the patient's need to have rehabilitation after surgery, and also cuts down on the time that the patient is really laid up with their tumor, right? So it really cuts down on kind of the process after surgery. So usually, especially with smaller tumors, right, where the balance nerve is still strong and good, right? We like that prehab, it's kind of opposite of what you may think, that the smaller the tumor, right, the more balanced symptoms the patient will have through radiation or surgery, right? And the larger the tumor, if you have these big giant tumors, patients don't even notice that we took it out, because the balance system has already compensated for that deficit, right? So it's really important concept that, again, smaller tumors, more balanced symptoms after surgery than larger tumors. And oftentimes you can attack those proactively by doing prehab, right? Again, vestibular physical therapy before surgery.
That's terrific. Everyone here, thank you so much for this. Those were terrific questions, terrific answers.
Thank you.
And patients are going to get a lot out of that. And I want to say that OSU Wexner, your entire team has been partners with us for quite some time, and it's always wonderful. So I really appreciate your time today and all of that information. I know the patients, what you do for the ANA and what you do for patients is terrific. So
it's our honor. Thank you.